Hey, welcome everybody. I'd like to welcome you to the 2018 National Healthy Homes Month webinar series. National Healthy Homes Month offers an opportunity to learn more about housing and its impact on health and provide resources to encourage local activities as well as empower families to protect themselves from hazards in their home. This June's outreach activities aim to greatly boost awareness and understanding of what federal and local resources are available to make a difference in the lives of all residents, regardless of where they live. For more information about National Healthy Homes Month, including resources for your program, you can visit www.hud.gov/healthy homes. Today's webinar is Bridging the Cultural Divide, the Role of Community Health Representatives Workers in Environmental Public Health, presented by Dr. Maureen Lichtfield, Professor and Chair, Freeport McMoran Chair of Environmental Policy from Tulane University, and Ray Lopez, Director of Programs and the Director of Environmental Health Services at Little Sisters of the Assumption Family Health Service in East Harlem. These are two fantastic, very qualified presenters. We're excited to have both of them here. A little bit more about the presenters. Maureen is the Director of GROW Research Consortium, Director for the Center for Gulf Coast Environmental Health Research, Leadership and Strategic Initiatives, Associate Director, Population Sciences, Louisiana Cancer Research Consortium. Ray is the Director of Programs. He oversees three areas: nursing, advocacy, and food pantry, and parenting and child development. As the Director of Environmental Health Services, Ray directs a team of community health workers who focus on asthma prevention using a holistic, hands-on approach, which includes conducting home assessments, remediating asthma triggers, and training of household members to improve housing conditions, indoor air quality, and improve health. We are pleased that you have joined us for this great event. This webinar series is sponsored by the HUD Office of Lead Hazard Control and Healthy Homes, USDA National Institute of Food and Agriculture, and the National Healthy Homes Partnership. This webinar will last approximately 45 to 60 minutes with 15 minutes at the end for questions. At the end of the webinar, you will be given information on links to additional resources for your program. We will be recording this webinar and posting it for you for viewing later if you prefer, or for viewing by other people in your office that could not make the webinar. Finally, we ask that you keep your microphone muted during the presentation. You may unmute your microphone for questions at the end. If you have questions before then, please feel free to post them in the chat window or the question window. I have talked to the presenters and they have requested that you use the chat window, and then between the two presenters, Dr. Lichtfield will go first. After hers, we'll ask for people to submit some questions. We'll ask her some questions, then Ray will present, and then we'll ask you to ask any questions that you have after his on both presenters. So welcome, and Dr. Lichtfield, would you give us a pleasure of go ahead and giving us your presentation?
Well, good day, everyone. I'm not sure where all the time zones are of all the presenters. I'm honored to be part of the family that we will engage in learning together. I always learn from this exchange as well. And so from a cultural perspective, I'll share with you a little bit of what's going on in the Gulf Coast with respect to community health workers. I'll take us a few steps back before we talk about community health workers and indoor air, making sure homes and other indoor air spaces are safe, by sharing with you a concept that we call a completed exposure pathway, but now focusing on the indoor air environment, and specifically indoor air environmental hazards. There are 5 components to this completed exposure pathway, and typically I tell my students that I should be able to wake them up at 2 a.m. and they should be able to tell me what those 5 components are. No, I am not sure that I can wake up 400 of you at 2 a.m. in the morning. And so let's hope that this sticks with you to some extent. So the first of the 5 components is, where does the hazard come from, the source of contamination? And we will go through each of these areas in detail, but for example, mold, air fresheners, and here is a little story. I work much, and I've worked a lot in indoor environments, and when we visit with our community partners, like you would do if your mom came to visit or if strangers come to visit, you want to make sure your house is extra clean. And extra clean means you want it to smell good. And so for homes to smell good, and particularly if you have mold in the home, you apply a lot of air fresheners and air sprays. That's exactly where the hazards are in. And so don't do that. Um, Thirdly, there are areas of homes or areas of the country where there are very old homes, including in New Orleans, and where we still have leaded paint on the walls. And lead-based paint is an area of exposure, is a source of exposure as well. And pesticides indoor, in every garage, in virtually every garage. If I would visit you, I bet I would find some Roundup or some other pesticide that you're using to have beautiful flowers in the spring and summer. So the source of contamination is important. Second is the component of a completed exposure pathway is how do the chemicals travel? And in this case, the chemicals travel by air. So you have to think about environmental media as the Ubers and the Lyfts of the world. And so air is one of those Ubers. The third aspect is how do people come in contact with these chemicals, and the exposure point is a nice way to express that. And so where are the indoor air environments? They're not only homes, but the schools, the businesses, and I'll pay specific attention to cars. In the United States, 2/3 of our life we spend in cars. We bring our kids up in cars. We read books in cars. I have meetings in cars and all the things you're not supposed to do in cars. And so cars are a very important indoor environment. The next component of a completed exposure pathway is now how do the chemicals get into our body? With respect to the chemicals and the hazards that are related to indoor air, they can get into our body in two ways: by breathing them in, inhalation, and by eating, by ingestion. Now, you would say, how can you eat air? There are little kids who do a lot of touching the floor and then putting their fingers in their mouth. And so lead-based paint, pesticides are the kinds of things that accidentally actually get into the body through ingestion. And then lastly, who is really at risk? And in a nice way to say that, who is the population that's vulnerable? And for indoor air, it's typically the elderly, the children, who are dependent on us to move anywhere or stay anywhere, and people with chronic disease, and in this case, chronic respiratory disease, so asthma and other chronic conditions. So I might wake some of you up at 2 a.m. Now, let's look a little closer to the source of contamination. I already mentioned mold. In the warmer areas, there is no way that you can avoid having some mold, whether it's in the bathroom or whether it's some other molded area. But if there are hurricanes and there are floods, then mold is a frequent contaminant indoors, including in schools. The second aspect of a hazard are particulate matters. Now, what is that? Those are those very fine pieces of dust that are fine enough so that you can't cough them up. Actually, coughing is a good thing. So after Katrina happened, there was this concern about the Katrina cold. Actually, it was a good thing because the larger the piece of dust, you can actually, the greater your chance to cough it up. But if they are very small, you can't cough it up, and then they end up in the lungs and they cause damage. Then we talked about the air fresheners and incense and all the beautiful candles you have to have a romantic bath. They're actually not good for you. Cleaning supplies, if you want to clean extra because your mom is coming to visit or your mother-in-law is coming to visit, not a good idea. Well, you should clean, but not use a lot of cleaning supplies. We talked about lead-based paint. I particularly want to pay attention to tobacco smoke. Not only first-hand smoke, but for kids and the elderly, second-hand smoke, and in fact also third-hand smoke, because it stays in the carpet, it stays in the upholstery of a car, and so second-hand smoke tobacco in general, first, second, third, are very important. And then there are our friends, the cockroaches. I don't know where you live, but in New Orleans, they are fat and big, and they're all over the place, particularly in the summer. You want to make sure that you don't have cockroaches in the home and other pets as well, pests as well. No, I hope you don't have cockroaches as pets. There's dust and dust mites, and those are typically in old mattresses. And then, yes, we love our pets, but there is also pet hair and pet dander that are sources what we call allergens. So those are all contaminants that we're worried about. Now, we talked about environmental media, the Ubers of the world, and in this case, it's air. Now, there is a misconception that outdoor air, for example, the outdoor air contamination after the oil spill, the 2010 oil spill in the Gulf of Mexico, is worse than indoor air. Well, I have some perhaps bad news for you, but indoor air is actually in most cases worse for people's health. And so as we look at now, knowing what the sources were, knowing that indoor air is typically more hazardous than outdoor air, now where do we come in contact with it? That's the third component. That's the exposure point. Often people think it's only in homes. It's not, because we are a very mobile society. We spend time in schools, we spend time in businesses, we spend time in cars, as I mentioned before. Our kids spend time in daycare centers, and our senior citizens spend time in senior citizens' homes. Those are all environments where indoor air quality is critical for people's health. And then we talked about we inhale it, we breathe it in, or we ingest it. We're particularly worried for kids who already have a tendency for being suffering from childhood asthma. We're always worried about the pregnant mom, and we're worried about the elderly, particularly people with chronic emphysema and other chronic pulmonary disease. So given that background, what role do community health workers play, particularly in addressing environmental hazards? They are very valuable. Community health workers are very valuable in addressing asthma, and we'll talk about one of those examples, diabetes, cancer navigators. But today we'd like to focus on environmental hazards. So what do they do? Community health workers are miracle public health professionals in my book, because they do anything from helping with assisting with access to medical care and non-medical services such as social services. They have a prime role in health education and outreach. They help patient navigation, as I mentioned before, but particularly they are involved in capacity building. And yes, they are very valuable and equal partners in research. And that's what we'll focus on today. So how do we train? We at Tulane train community health workers. It's an 80-hour competency-based training that has two big buckets, so to speak. The first bucket is the core public health issues, such as what is public health, the social determinants of health, but particularly also cultural competence. We cannot, as a multicultural person myself, we know that we can never be culturally competent. We can strive to be that, but we're never totally cultural competent. And if we had more time, I'll tell you all sorts of stories of me being culturally incompetent, but maybe that's for another time. And then there are specific field experiences that community health workers share with each other so that they can learn from each other, and the specific role in health education. Now, from the second bucket are specific topic areas. Now, we call them specialty public health topics. Those specialty public health topics are absolutely driven by the target audience that's served by a community health worker. So whether it's environmental health, or there are real problems with obesity or diabetes or cancer, or in some cases, particularly in warmer areas, Zika and dengue. And my work in Suriname involved community health workers and suicide attempts. those are areas that we teach our community health workers so that they could be useful and a critical component of helping people be healthier. And so we already mentioned how community health workers can be involved, but particularly for healthy homes, they can point out indoor air hazards. They can particularly show ways how to reduce those hazards. Overall, we are striving to improve environmental health literacy among all of us, wherever we live and wherever we work. So today I'm going to use two examples of studies where community health workers were involved and their very important role in how they made a difference. The first of those studies is the Head of Environmental Asthma study, HEAL, called HEAL for short. And this study happened a year or so after Katrina, when we were worried that we would see an increase in childhood asthma, and particularly in childhood asthma attack, because of the tremendous amount of mold that were indoors, that were in homes, because 80% of the city was flooded for about 4 to 6 weeks. And so we wanted to see what mold as an allergen would do with kids and asthma. And we focused particularly on kids with moderate to severe asthma. The children that were pre-screened for eligibility by phone, where we involved and reached out to caregivers and asked about their child's asthma symptom. In the end, we ended up, and it took much longer than we had expected, but in the end, we ended up enrolling 182 children. Now, how were community and health workers involved as asthma counselors? They provided both critical asthma case management, but they also helped us guide the environmental remediation to help, again, remove the exposure, to help remove cockroach and dust mite. We put tools in to measure the air quality. There was a specific in-home evaluation where we actually took samples from air and from dust and analyzed those. And the community health worker was critical in following up with the caretaker 2 weeks after each in-person session, so that we could see whether indeed we made a difference. But I want to share with you, because some of you might face this as well in the future, how critical the community health worker was in not only implementing the research study, but even starting the study. Our recruitment was not as typical of putting out an announcement on whatever social media and they will come. No, our recruitment was in schools, in daycare centers, in Head Start facilities, and we approached about 2,500 plus people who we thought we could enroll, and that would be, as an epidemiologist, you always like that. Now, it turned out that we needed real cultural help, because a number of caretakers who answered, yes, my child had asthma, actually meant something totally different. Because there is within some communities, there is an understanding that eczema is also asthma, but it's asthma of the skin. And so we had to exclude a number of children who had eczema and not asthma of the respiratory system. And so we had a pre-screening done, as we mentioned before, and then that was followed by clinical screening, both at baseline and at 12 months. And I share again with you the role of the community health workers, because we couldn't expect that after such a major disaster as a hurricane, they would just come, moms would just take, or caretakers would just take their child to the hospital. And so working with community health workers to understand the situation, we actually prepaid taxis for them so that they could come. And we made 3 times as many calls, sometimes up to 8 calls, to make sure a child would come for the clinical screening. And still, we had a 50% no-show rate, even if we called the morning off. And that's not because caretakers were bad, it's because they had such difficult times to deal with other problems in their life. Now, we follow that up with environmental assessments at baseline, at 6 months, and at 12 months, in addition to follow-up telephone interviews, looking at asthma, particularly focusing on asthma-free days. But it really was the participant-tailored asthma counselor intervention that made a difference in this study. So let me share with you what the difference was. One of the lessons we learned is that we couldn't advance with the study if we really held to a strict, very rigorous time frame, because often when we visited, the caretaker wasn't home or couldn't be at the specific time that we had the appointment. And so by decoupling the visits after the 6-month home evaluation, we were able to implement the asthma counselor intervention without delay. We would never have known that had we sat in our nice offices at Tulane to implement the study. What we were particularly proud about is that we compared our results in looking at how we decreased the symptom-free days with the inner city asthma study that existed long before our time, and the natural cooperative inner city asthma study involving multiple cities in our country. And as you can see, statistically, we fared in the same way, had the same kind of effect, despite the challenges that we dealt with after Hurricane Katrina. And so that's one aspect. The second study happened after another disaster, and this was a man-made disaster, the oil spill of 2010. As part of the medical settlement, we actually not quite as part of the medical settlement, but in another case, yes, we also worked very closely with community health workers as part of the medical settlement. But we were funded very uniquely by the National Institute of Environmental Health Sciences to build resilience through disaster mobile health. And we did that by enabling community health workers to work with us to do that. And so we designed a disaster mobile health platform to improve community health, community resilience, and we did that focusing on a very specific population, and those are women eligible for the WIC program, the Women, Infant, and Children program. And so we trained community health workers who were affiliated with that program to serve as disaster interventionists. And we wanted to see whether their role would actually help us not only deal with getting better pregnancy outcomes and birth outcomes, but we also wanted to see whether it helped women prepare better for the disaster period or the hurricane season that we have every year. And so in this specific study, we linked each participant with a community health worker, and we involved the community health worker with data collection, with follow-up with each of the participants, with case management, and particularly to engage the broader community. In the end, we had a population of 141 pregnant women who were WIC eligible or who used WIC. We did that doing away with paperwork, but using iPads in a two-way mobile technology fashion, where we helped with scheduling. We provided both one-way and two-way messages, and particularly focused on health education. And so here is one aspect of the study showing clearly the role of community health workers. We asked our participants how the text messages were helpful to them while they were pregnant, after they delivered, working with the doctor or the provider about the topic that was mentioned in the text messages, whether they did ask their doctor that, whether they did use the resources that we provided them, and whether they indeed updated their hurricane preparedness plan that we want everybody to do. And so using this mobile health technology, this mHealth strategy, we developed an interactive model for communication to educate and prepare the public. And we used what they use, so readily accessible and effective methods of communicating. So what we are able to show that the women who found the text messages helpful were 87% more likely to update their hurricane preparedness plan. Now, that's no small accomplishment. Not that I claim it. No, the community health workers really were instrumental in making that happen, and that's critical. That's life or death for us on the Gulf Coast. And so in sharing these two examples with you, we clearly show the effectiveness of a hybrid counselor and environmental intervention. So the role of a community health worker, both as an asthma counselor and a disaster interventionist or environmental health interventionist. We clearly showed to the GROW study the potential for using mobile health technology in a healthy home intervention. But ultimately, none of these examples are good enough if we can't create a permanent or at least a sustainable way for keeping our homes in all of our communities healthy. Because the community health workers are not always in the home. So how do we make that knowledge stick? And that's something that I'd love to discuss more with you. And what else can we do together to keep people healthy in their homes, in their schools, in the daycare centers? Ultimately, I think one effort we're currently focusing on is improving environmental health literacy so that together with community health workers, we can get even greater results and make even a greater difference. So let me stop here if there are any questions, but particularly looking forward to the interaction after both of our presentations. Thank you.
Maureen, that was fantastic. Right before we go to Ray, there is a really quick question that came in that will be quick. One of the participants asked, which community health work training were you referring to an earlier slide about the general public health? Could you clarify that just a little bit?
Yes, that is our own training. That's Tulane's training that we developed. It is the difference, and we're about to publish that manuscript. The difference between, there are plenty. Thank you so much for that question, first of all. There are plenty of community health worker training programs out there. Very few actually are competency driven, and ours is. And so from a general public health perspective, we touch on the aspects of public health that are instrumental and meaningful, not only as community health workers are on the front line in the field, but also gives us a good foundation, kind of like the floor of the home, to build on specific other specialty components. Because I couldn't do a specialty module on, and those specialty modules, by the way, are two-day modules. I couldn't do any module on environmental health if I didn't build on basic health. I couldn't do a module on obesity if we didn't talk about walkability and the built environment as part of the broader public health topics. And so we looked at the many trainings that were out there, and we actually convened an expert panel and came up with a set of competencies that we're about to publish.
Thank you, Maureen. We do have 3 more questions, but I want to go ahead and let Ray present, and then we'll ask questions for both of you. So thank you, Maureen.
Thank you.
Ray, you're on.
Hi. Thanks, Michael, for introducing me. Thank you, HUD Office of Lead Hazard Control and Healthy Homes, for inviting me. And thank you, Dr. Lickfield, for sharing your time with me. My name is Ray Lopez. I am the Director of Programs and Director of Environmental Health Services at LSA Family Health Service. I've been working at this community-based organization, which is based in East Harlem since 2001. Um, and I started by working with the nurses here at Little Sisters. I'll give you a little bit of history of the Little Sisters. It's a nursing order from Paris dedicated to helping the sick poor. They actually they found across the globe and moved to the Lower East Side in New York City in 1891, but moved up to East Harlem in 1958 and became a nonprofit. And these nuns were trained nurses and social workers. And so our visiting nurses were our first program, and quickly the wraparound programs began to develop in early childhood care. Also, we established a thrift store, food pantry, and advocacy, and then the program that I'll talk to you about, which I've developed for asthma. Just a quick show of the demographics of the clients we serve here at Little Sisters for all of our programs, primarily a Latino population with some who come from rural parts of Mexico and other parts of Central America. So language is a challenge for many of our folks. You can also see that housing is really at a premium here at East Harlem. Lots of families are doubled up, and either living in various types of shelter or Section 8 housing. Just to show you a quick map here of New York City, and East Harlem is, if you can see my mouse here, right there, smack in the middle of the city. And when I started here in 2001, East Harlem had the highest pediatric asthma hospitalization rate in the country. Because of programs like mine and Department of Health and other partners, we see that East Harlem is a little more in the middle of the pack, but still with many issues. So about 20 years ago, our visiting nurses just saw the extreme need for working with people who have asthma. The nurses, while they could go into the home and teach families how to administer the asthma medication, how to assess the home environment and reduce their triggers, they could not spend a lot of time in the home because they would only be approved by the health insurance to do 2 or 3 home visits, and which is really not enough time to work with the family to improve the home environment. So the nurses created a position for a community health worker to spend more time with the family, approximately a year, and to complement their work and their education, to really take a hands-on approach, not just assess the home environment, but to teach people how to mitigate those asthma triggers by doing it alongside them. And this has become sort of a distinguishing feature of our program, where our community health workers are trained to do the actual remediations. Our workers are certified pest control technicians and also lead risk assessors. And so they have the ability to really essentially do what it takes and fill in the gaps in the health system in general. Another aspect of our work is that we do the advocacy work. We teach people how to advocate for themselves, and we collaborate with community organizers. Because of our long history in the neighborhood and the fact that we recognize that there are, many buildings in distress, and that referrals come to us many times at the same building addresses. This is some of the equipment that we use on our home visits, basically a HEPA filtered vacuum cleaner and an air purifier. Over the years, we've purchased almost 100 air purifiers, but rather than give them away, we loan them out and triage them. So we've essentially created a long-term air cleaner loan program while we work with families to complete the repairs in their apartment. So here's some images of our workers doing some of the integrated pest management work in the homes for cockroaches. During this time of the year, we see a lot of see an uptick in bed bugs. So we teach people so the integrated pest management approach and apply it to all sorts of pests that they can encounter, including mosquitoes, which are also starting to become a problem. So I'm going to show you just some images of a home that we encountered some years ago in our care program. Here's an apartment that we saw in our first home assessment that, to someone a little more experienced, obviously there is water damage that may have, the water source may have been resolved, and so the wall is drying out. And this wall is the kitchen wall that's sort of adjacent to this bedroom. And here we did a field training with our workers, just looking at the damage, learning how to do a basic lead test swab, assessing the headboard, and we practiced setting up a barrier to reduce the occupant's exposure. Obviously, took pictures and documented the conditions, and HEPA vacuumed everything that was sort of loose and falling. And this kind of issue was reported to the housing authority and was repaired. So this is a nice, clean-cut, positive story to share. Here's the kitchen that actually had to get its cabinets replaced because they were rotting and falling off the wall. So, I think that probably preaching to the choir. I mean, we all know that these community health worker models work. The evidence has built over the years. We've demonstrated it with our own data, as well as with many of the partners that we work with in research. And in the course of this partnership, our community health workers are not just doing the intervention; they are participating in the planning, design, intervention, and also in dissemination activities. These are some results from our first HUD-funded study, which is I think their first asthma grant in 2011. So here you see a reduction in the use of rescue medication and also healthcare utilization. Even though the results I showed you were nice, positive, clean cut, there's still a lot of issues that we see. So, I wanted to show you the full community health worker scope of practice. And, one of the things that I told my superiors here at Little Sisters early on was that, that I don't think I could sustain doing this work, only helping the individual families one at a time. That, to do this work and to ignore the broader structural problems that put people in positions where they're living in substandard housing and that there aren't resources available to address them, I felt would not make for a complete program and would not be sustainable for me. So luckily, the nuns here and my superiors told me to go ahead and run the program as I see fit. So one of the things I did was I partnered with a community organizing group called Manhattan Together and the Industrial Areas Foundation. They were able to help us meet with decision makers at the New York City Housing Authority to help address unresolved repairs. But as you see here, we did it for 10 years, and over time, it just took us a lot more time, and we just saw less positive results over time, and just felt like we needed to do a little bit more to improve our success rate of getting repairs done in people's homes. So we partnered with other organizations, public interest legal organizations, to look at other ways to take what we were seeing in people's homes and to try to affect change in a systemic level to reach people that we aren't able to reach individually. So the National Center for Law and Economic Justice, Natural Resources Defense Council together came up with the context of using reasonable accommodations, which is Americans with Disability Act, and as a rationale for placing a claim in federal court. I won't get into all the details because, as you can see, it's a very long process, very long timeline. But you know, we were able to do a lot in terms of getting the Housing Authority to comply with the Disability Act, to overhaul their mold and moisture policy, and to report on their performance on a quarterly basis. They also agreed to speed up their timeline, which we are seeing to some extent, although now we're working on improving the quality of the work. As community health workers, we have an important role too to share some of the stories and some of the experiences that we see on the ground. So we were lucky to collaborate with Dateline NBC to tell the story of asthma and its effects on people. This link actually is not working at the moment, but it's something that I hope to share with the group on a future date. As I mentioned earlier, we have strong collaborations with research partners who have included us in the writing and interpretation of the intervention that we participate in. And so this is one of the places that we publish thanks to the New York Academy of Medicine. This is as a result of that first asthma study, first HUD-funded asthma study, we also interviewed participants and really received a lot of rich feedback about our program and about sort of the qualitative, soft, sort of interactive things that really help to improve engagement. So, you know, when this program started 20 years ago, there was only one community health worker on staff, and there are now 7 of us. And so in that expansion, there really wasn't an easy way to identify and hire community health workers. Sure, you know, we have the Community Health Worker Network of New York City. And we have other organizations that are more and more using community health workers. So, you know, I think that employers like myself and others usually stick to finding people with specific attributes and then finding the training for them. this specific training for environmental health. Currently, we've merged our study with the New York Academy of Medicine with Columbia University's Mailman School of Public Health, and we're looking at fungal exposure pre and post intervention. So we're enrolling new families now, and we're performing our intervention, and then we're going back to take dust samples and looking at the sample to characterize the mold exposure. And we're also going back in the other arm of the study to people who were in the first study 2 to 5 years ago. So, all of this work from a program like mine, which is a standalone community-based organization, not embedded in a health system or in a research academic institution. We've had to collaborate in research, but we've also always had an eye on integrating our workers into the healthcare system. And so we've finally gotten that opportunity through New York State's Delivery System Reform Incentive Payment Program, DSRIP for short. And currently we're a couple years into an asthma project with One City Health. And it hasn't been easy for our organization because we have partnered with 4 different sites and have embedded community health workers in each of these sites. And so it's been complicated for us, culturally to put ourselves into these hospital and clinic systems and to learn how to navigate them and relate to the different people who work there. It's also been difficult because of data sharing and the full integration of our workers into the care teams. Finally, I showed you that we do these hands-on interventions, but in part of this project, we're not doing those hands-on interventions. That work is outsourced to a pest control company. And, and that complicates our abilities to provide the intervention that we're used to providing. It's a tension that we're still sort of trying to figure out. For our organization, it's been a pleasure to work with the different partners. We know that this problem of asthma is bigger than any one organization, and so we've worked hard to develop our relationships, and we feel that relationships are foundational. Whether it's between the community health worker and the caregiver and family, or between our organization and others. And I truly believe that the work that community health workers perform every day have the potential for impact on structural changes. And I'm hoping that this will be a way of reducing disparities and improving health.
Ray, thank you. That was a wonderful presentation. We have a lot of questions for both presenters, so I'm going to attempt to answer them. And let me change it to the blank screen here. Okay, so a couple of questions that have come in. We'll start with some for Ray, and then we'll go to back and forth with Maureen. There's a lot of questions here. Actually, let me ask the first one to Maureen. I did get a participant who asked whether your community health workers have iPads, and we also got one, where would they look for the published training that you have?
So yes, the community health workers were not only but had iPads. We bought iPads for them. They were connecting to the participants by cell phone. They did all the questionnaires on the iPad, and then the iPads were encrypted. But every day they would come back to our office, and we would upload the data onto a secure server, so that if something happened, the iPad got lost or the iPad was stolen, that personal data with personal protected identifiers were not there. We are about to publish that curriculum, and so as soon as we publish, we will share that. I also was encouraged, maybe there's a question coming back, the really outstanding presentation that Ray did, to share with you another way where we had embedded community health workers. As part of that medical settlement, not included in my presentation, we trained and embedded, working with 23 community-based organizations and federally qualified health centers all along the Gulf Coast, community health workers who deal with a number of issues, not necessarily indoor air, but who deal with diabetes, hypertension, cancer, and the work and the impact that they're making, access to care to their communities, is absolutely phenomenal. And what we did, unlike other ways, we didn't employ the community health workers. Actually, we had subcontracts with community-based organizations and federally qualified health centers, for within whom we also provided salaries for not only for the community health worker, but salaries for the supervisor, so that there was buy-in and we could do an evaluation. That all that information we published in a special issue of the Journal of Management and Public Health Practice last November.
Thank you so much for that answer. Ray, one of the questions is, does New York have a state certification for community health workers?
No, they don't. I think that it's being discussed within the Medicaid redesign, and so basically it's been sort of on a contractual level, and so with our contract with the city's health and hospitals, there are provisions in the contract specifying the kinds of trainings that are required.
There are several states who do, to build on what Ray indicated, but Louisiana does not. We're indeed working with our state health department here, and therefore that was one of the critical drivers for us to develop this competency-based training curriculum, so that every organization, wherever they are, or whether it's a community-based organization, could use that.
Thank you. Okay, so Ray, this is for you. The question that came up was, scrolling pretty fast here. So this is actually from Peter Ashley at HUD. So Ray, getting lead risk assessment certification and pesticide licensing for community health workers is a higher level of technical training than I've seen in most programs. Do you think that's replicable by most programs? Is there required level, hold on. Is there a required level of formal education for community health workers?
No, so we started this at a time where there weren't a whole lot of resources, or there were, but they were difficult to access, and so we just wanted to prepare our workers to be able to encounter whatever it is that they were seeing in the homes. And so, it's been sort of individualized. We currently don't have someone who's a lead risk assessor. We do have a pest control person on staff. Luckily now there's some more resources citywide, so we can interface with them. But I think our workers still should be able to recognize and share best practices for all of these healthy homes conditions that they encounter.
Thank you. I'm going to read a comment from a person, actually it's multiple people with the same comment. So the people from Texas had a good comment that Texas was the first state to develop a community health worker certification program. a couple of people who work for the state health services mentioned that, and they think that they were the first ones, and that there's a couple of people that said that that's good in Texas that they have that. I want to answer a question that's mostly for me, and then I'll go back to the presenters. A number of people asking about copies of the PowerPoint slides and the recording of the presentation. What we do is we have a number of websites, including at HUD Healthy Homes webpage that we post these. It takes about a few days to process them, and then the PowerPoint presentation, the recording, will go up, and then we send an email to all people who have registered for these webinars, giving them the direct link for that. So you will be able to go back to this recording or share it with other people in your office. Let's see here. So one of the questions that came in is, this is from Maureen, besides education, how did the community health workers help improve the indoor air quality? For example, how did they get rid of mold in a home?
And so we trained them to work with the community to show them how to do it. But what we didn't do is do it for them, because we felt that if they're not invested in doing it themselves and not doing it while they were and not doing it themselves, they wouldn't be able to do it when the community health worker was gone. So what the unique aspect is, what we did is we linked the community health worker. First of all, they never went to a home by themselves. They were always two of them went. And secondly, we linked the community health worker either with a graduate student, but particularly with a faculty member whose expertise was in mold. And so I think there was kind of a team learning experience for the participants in their home and outside their home. We also worked with school teachers and principals and did the same kind of education, but the intervention itself in the home, we taught the participant to do it, but for them to do it, not for the community health worker to do it.
Thank you. We have quite a few more questions, and I will be glad to answer to ask all of them for everybody. If everybody's okay with that, and the presenters, if you can hang on just a little bit longer, because these are really great questions and fantastic presentations. So I can definitely understand why people are asking these questions. The next question, I believe, goes to both presenters. What are some of the funding streams used to hire the community health workers to work with your organizations?
So from my perspective, the funding stream, and this was a first also for Tulane, came from both research, in this case, the National Institute of Environmental Health Sciences, or NIH, as well as from as I mentioned, the other part that I didn't include in the slides, from the medical settlement after the oil spill. I want to say something specifically about how we can include community health workers in research. It isn't easy, because after Katrina, actually after the oil spill, also we went to the community, and I worked for years and years in these communities, but I can't, as you hear from my accent, I clearly am not from Louisiana by birth. And we asked them what their concerns were, and they said they had three concerns. What will happen to our babies? Will the seafood be safe to eat? And will the air be safe to breathe? And we took those three questions and created a full consortium of projects. I just presented one to you. Around using a community-based participatory research design. We also were required to create a community outreach and the dissemination core. There are two additional articles, Michael, that I'm happy to send to you when you send out the slides, where we actually published a unique experience, and that is that the community members took hold of the research and created a curriculum to teach the faculty how to disseminate and translate environmental health information. And then the other article appeared in AJPH a couple of years ago, American Journal of Public Health, where we talked about, from disaster to dissemination, the role of community-based participatory research in the aftermath of a disaster, because that is somewhat different than when you do it, quote, in normal situation. situation. So I'll share both with you.
I appreciate that, and I will be glad to upload those with the recording, everything. Really quick answer also that's coming in. I know a lot of people who are on this webinar and earlier webinars are asking about certificates for continuing education, because this is an excellent webinar series that HUD provides. What we usually do is upload that to the website that the recording's at, and you can download it and put your name on it. So if those of you asking for that type of certification, we will provide that in the near future. We'll probably be able to do about 2 more questions because we don't want to keep the presenters all day, although the presentation was so good, I'm sure we could ask questions all day. Someone asked about the Baez case. Was the ruling now federal law?
No. So it's a settlement, and we are still sort of in verification mode where we're trying to make sure that NYCHA complies with the settlement. And actually, the settlement was set to expire in April, and we agreed on continuing it for a longer period of time in order to see if the sort of the pilot study that was designed, in fact, improves the results. So yeah, it hasn't affected federal law.
Appreciate that. So a couple more questions. I appreciate everybody's patience on this. So someone from Arizona is asking how are CHRs and CHWs different? And they're speaking on behalf of Arizona, where I believe the designation is CHRs. Is that something that either of you can answer?
Yes, and in fact, I thought I presented on a different webinar with someone from Arizona, and they're doing really good work too. So in our soon to be out manuscript, those are the issues we address. There are a number of ways that community health workers are designated, either by community health advocates or community health representatives, or and so promotoras, and there is these are all good, but it creates chaos in the field, and it hampers actually the professionalism, what's very rightfully so, as Ray indicated in his examples of the community health worker profession. And so what we're doing in the article is to design and actually describe 4 tiers of community health workers. So at the first tier, which typically is where the health advocates are often grouped, is where these are often volunteers. They're often not paid. They're often not they don't necessarily have a professional degree, but they do outstanding work, and there's training related to that level. Then there are the community health workers that are involved in our programs, where they are employed, some part-time, some full-time, and where there is a more competency-driven education where we can document performance and measure competency, document learner performance and measure competency more from a 360 level. And then there are the third level, a third tier, so to speak, our community health workers who really have been trained as disease-specific interventionists, the asthma counselor, the diabetes navigator, the cancer navigators come to mind. There they are most often full-time employed, and many have also at least an undergraduate and sometimes often a master's level education. And then the fourth tier, which is really not a tier of community health workers, but those are navigators, those are people who are in the hospital setting often, who are part of teams. So they are critical to navigate a patient within the hospital team, within the clinical team, for any of the chronic diseases. And so those are professionals, those are nurses, those are formal health educators who have health CHES, who are certified as a health education specialist. But because of this variability in the field, we felt compelled to provide a good description and somewhat of defining the field. Now, Ray started off one of his earlier slides in correctly pointing out the importance of the scope of practice. I think until we link competencies, and now I'm speaking more of as an educator, until we link competencies to the scope of practice, we're not going to be able to, one, define the field and to advance the field. And we're hoping to address that in our upcoming manuscript.
Okay, look forward to seeing that. So one last question for everybody. So the question is, the CHRs in Indian country type in their data into the Indian Health Service computer software for their own tribe. I wanted to know if CHWs do any data entry to verify if a service was provided for the provider or nurse to see, such as when a CHW does any educational presentation on your topic, such as asthma education.
Ray, why don't you take that one first, and then I'll respond.
Sorry, I didn't hear the question.
Oh, no problem.
I did want to respond that I think that the community health worker field is still in development, and I think that the most important thing is for all the professions to support the field, but also to allow the community health workers to also be a part of that discussion, and in their experience to share how it is that the profession should be defined and developed and certified.
So the question, Ray, was asking about data entry by the CHWs. Do they do any data entry to verify if a service was provided for the provider or nurse to see, such as when a CHW does any educational presentation on your topic, such as asthma education?
So I didn't quite understand the question, but we document all our visits on our own database, and depending on the project, and if we're sort of linked with the provider, we will share our findings with the healthcare team electronically, sometimes in person, sometimes over the phone.
Last thing. Go ahead.
Yeah.
Go ahead.
So just to add, to actually bring up an important point that Ray brought up. As part of our expert panel, we actually had community health workers help to define the competencies because they're in the field, as you said, and so we wouldn't want it to be an academic exercise. So thank you for pointing that out. In terms of data collection, yes, so in our research projects, the community health worker collected using standardized surveys, collected information from the participants, and as I mentioned before, we then uploaded it in a secure encrypted site because of confidentiality and HIPAA requirements. From a practice perspective, those that are currently in the field as part of the medical settlement, that's where it was so critical for us to also engage the supervisor because the data that are collected, not only the performance of the community health worker, but the difference that they make. For example, one of the major roles of them is referral into the primary care system and specialty referrals, in this case specifically to environmental medicine specialists. And so we want to know what happens afterwards. So yes, that is documented for the clinics, that's documented in the electronic health record, and for the community-based organizations, while it is not often very quantitative, we collect qualitative information through the evaluation component for which the supervisor is responsible.
Thank you. So I know we have a few more questions, but I'm going to ask a favor because I mean, obviously we're going a little bit excess of an hour. Ray and Marie, could you give your email address out one more time so if people want to contact you, they know how to get a hold of you? And then before you do that, I want to mention that that for those of you who are asking for CEU certificates, we will upload copies that you can use to the website when we post the recordings and the PowerPoint slides. So last comments, Maureen and Ray, and if you want to give out your email address for follow-up people to contact you.
Yeah, Ray has his last slide up. So Ray, do you want to go first?
Sure. rlopez@lsafhs.org. Please feel free to.
And my email address is on my last slide as well, Michael.
Yeah.
And it's mlicchtve@tulane.edu. And I can show my screen. Yes, I could do that. And can you, if you go to the last slide, yeah, right there. So it's a difficult Dutch name, but you can find it, and looking forward to your emails. It was an honor to be with you, and we all have an obligation and a commitment to make our communities healthier, and we can't do this without community leaders who are our community health workers. Thank you very much.
Thank you both for this incredible presentation. I appreciate all the participants. This is one of the largest National Healthy Homes Month webinars that we've held. And I hope everybody has a good rest of the day. Just a reminder that we do have a few more of these webinars coming up. If you go to the HUD Healthy Homes website, you will see the list of the remaining ones, and all of the ones you may have missed are recorded and will be available to you for future viewing. I'm going to go and stop the recording, and this will be the end of this webinar.